So the next question is, which of the following method is the most effective for inactivating the hepatitis B virus on contaminated dental instruments? The options are autoclaving at 121 degrees for 15 minutes, soaking in 70% ethanol for 30 minutes, then washing under hot running bath, then soaking in glutaraldehyde for 10 minutes. So the best method for inactivating the hepatitis B virus which are contaminated on the dental instrument is autoclaving at 121 degrees for 15 minutes. Now, if you take this hepatitis B virus, this is a highly resistant virus. Right, so this is the highly resistant virus, and autoclaving is the most effective method, right? It is the most effective method for inactivating the HBV virus. Now, what about the other options? So autoclaving, this is like the gold standard. This ensures complete sterilization. This autoclaving will not only kill the HBV, it will also kill the HIV and as well as its spores. And what about 70% ethanol for 30 minutes? 70% ethanol for 30 minutes, it is ineffective for HBV and it is not reliable for the complete inactivation. And next is washing with the hot water. So washing with hot water, it removes debris but does not sterilize or inactivate the viruses. That is about washing with the hot water. Next is glutaraldehyde 10 minutes soak. Glutaraldehyde 10 minutes soak, it is a high level disinfectant, but it requires almost 20 minutes or more to be effective against the HBV virus. So this is about the other options. So the best method for inactivating the HBV virus on contaminated dental instrument is autoclaving at 121 degrees for 15 minutes, right? Now we'll move on to the next question. A 45-year-old male with cirrhosis and thrombocytopenia, and the platelet count is around 45,000 per cubic millimeter, presents for the tooth extraction. What is the most appropriate management in this patient? Proceed with the extraction without modification, delay extraction and refer for the platelet transfusion, perform extraction with the antibiotics, use aspirin pre-procedure. Now the patient is having the platelet count of 45,000, which is like thrombocytopenia, and this particular patient presents with the tooth extraction. So what is that you need to do is you need to delay the extraction and refer for the platelet transfusion, right? So any individual with platelet count less than, right? So any individual with platelet count less than 50,000 per cubic millimeter, they are at risk of the excessive bleeding. Right, they are at risk of excessive bleeding, right? So transfusion is needed before the invasive procedures, right? Transfusion is needed before the invasive procedures. So normal platelet threshold for minor dental procedure, how much it should be? This should be around 50,000 per cubic millimeter. That is for minor surgery. So this is the, right, so this is a threshold for minor surgery, including the dental extraction. And the threshold, right, it is less than 50,000 if it is there. For this minor surgery, what is the problem? This increases the risk of bleeding. Right, so this increases the risk of bleeding. So that is the reason why you need to delay the extraction and you need to refer for the platelet transfusion. So if you take the other options like proceed without modification, so this will be like completely unsafe and there is risk of bleeding due to thrombocytopenia. So first option is incorrect. And second option is correct, that is delay and refer for the platelet transfusion. Okay, so you need to increase the platelet count above 50,000 per cubic millimeter before the extraction, and that is a true statement or correct statement. Perform extraction with antibiotics. Antibiotics do not address the bleeding risk. So antibiotics do not address the thrombocytopenia. So incorrect. Use aspirin pre-procedure. So this aspirin increases the bleeding risk. So that is the reason why aspirin is like absolutely contraindicated, right? So the correct answer in this is you need to delay the extraction and refer for the platelet transfusion. Done? Now, after this, if you see the next question, a dental intern is exposed to the blood from patient with the HBsAg positive, anti-HBs negative and anti-HBC positive, but IgM is negative. So what would have been positive? That is IgG, anti-HBC would have been positive. What does this indicate? Vaccinated and immune, past resolved infection, chronic HBV infection, acute HBV infection. So IgG anti-HBC positive, what is it suggestive of? This is suggestive of the chronic HBV infection, right? So the point here is the individual is having the HBsAg positive, then IgM, right? IgM anti-HBC is negative. So this indicates that the person is having a chronic infection. IgM is negative, but anti-HBC is positive. What it would be positive? IgG would have been positive. So that tells it's a chronic HBV infection. So the pointers here are HBsAg positive. So let me tell you, if this particular HBsAg is positive, what all it represents? So this represents that the individual might be having an acute infection, or this represents that the individual might be having a chronic infection, or this represents that the individual is a carrier. This represents that the individual is a carrier. So HBsAg positive indicates that there is an HBV infection. Anti-HBsAg negative, right? So anti-HBsAg is negative. So anti-HBsAg is negative. What does this anti-HBs tells you about? The anti-HBs, this tells you about the immune status of the individual, right? So this tells you about the immune status. So anti-HBsAg negative means no immunity has developed, right? No immunity has developed. Next, anti-HBC is positive. Anti-HBC is positive. So anti-HBC is positive means the individual is having either acute or chronic. If suppose IgM is positive, then it is suggestive of acute, but the question says IgM is negative. So what should have been positive? IgG would have been positive. So IgG positive tells you it is like chronic infection. Okay, so IgM anti-HBC negative tells you that it is not an acute, it suggests the chronic infection. So this individual is having a chronic HBV infection. And what about the other options? Like what should be the serology in vaccinated individual past resolved infection and acute HBV infection? So in case of the vaccinated and as well as the immune individual, they should be having the anti-HBs positive. Okay, so our patient, the anti-HBs is like negative. So this will rule out. Past resolved infection, what should have been positive is anti-HBs should have been positive and HBsAg should be negative. So this is not the scenario with our patient. Chronic HBV is the correct statement in this question. Whereas acute HBV, IgM should be positive. But in the given question, the IgM is negative. So your option D is also incorrect. So what is the correct statement here? Option C is correct, right? And for the hepatitis B infection, how do you decide the treatment? So if it is an acute infection, we don't require the antiviral drugs. It is just only symptomatic treatment, right? So it is just only symptomatic treatment. Whereas if it is like chronic infection, then you need to decide the treatment based on the HBV DNA levels. Now if suppose if the HBV DNA levels are more than 2 into 10 to the power of 4 viral DNA particles, then you need to start the treatment. So how is that you need to start the treatment? The drug of choice will be entecavir, or the other drug can be tenofovir. So tenofovir or the entecavir can be started. We also have a pegylated interferon, but they are the parenteral formulations. So this is about the chronic HBV infection. How do you treat? Now moving on to the next question. Which local anesthetic is safest in patients with advanced liver disease? Lidocaine, bupivacaine, then prelocaine, then articaine. Safest. So safest in advanced liver disease is articaine, because if you see this articaine, it is metabolized by plasma esterases. Right, it is metabolized by plasma esterases, but not the liver. Right, it is metabolized by plasma esterases, but not liver. Okay, that is the reason why this articaine is like completely safe in the liver disease. Whereas you take the other molecules, you take lidocaine. Lidocaine, it is metabolized mainly in the liver. Right, and within the liver, it is metabolized by CYP enzyme. Right, it is metabolized by CYP enzyme. Okay, now because this lidocaine is metabolized in the liver, this lidocaine should not be used in the advanced liver disease. Then next is the bupivacaine. So bupivacaine, even this also undergoes the hepatic metabolism. Right, it is metabolized in the liver. So this bupivacaine, this whenever you give in the patients with the liver impairment, these patients will be having a prolonged half-life. And the same scenario is like prilocaine. So if you take this prilocaine, it is metabolized both in the liver and as well as in the kidney. And the problem with the prilocaine is this can cause, right, so this can cause methemoglobinemia. Right, so this can cause methemoglobinemia. Right, so that is a problem with the prilocaine or adverse effect. So now because it is metabolized both in liver and as well as like the kidney, this has to be used cautiously. Right, so this has to be used cautiously. So which local anesthetic is safest in a patient with advanced liver disease? That is the articaine, because it is mainly metabolized by the plasma esterases. So this is like preferred in the liver disease, right? Now you see the next question. So a dental student gets a needle stick injury from an HBV positive patient and is unvaccinated. What is the next step? Observe the patient for 6 months. Administer hepatitis B vaccine only. Administer both hepatitis B vaccine and as well as the hepatitis B immunoglobulin. No action is needed if liver function tests are normal. So this particular individual is pricked with the had a prick from HBV positive patient, and the individual is like unvaccinated. Okay, so you need to administer both the hepatitis B vaccine and as well as the hepatitis B immunoglobulin. So unvaccinated individuals, when they are exposed to this hepatitis B virus, they require both. So they require the active and as well as the passive immunization. Okay, so you take this active immunization, that is hepatitis B vaccine. You take the passive immunization, that is hepatitis B immunoglobulin, right? So now you take this hepatitis B immunoglobulin, that is your passive immunization. This has to be administered within 24 hours. Right, so this has to be administered within 24 hours. Okay, so this is about like what you have to give in case of unvaccinated individuals. And what about the other options? So observe for 6 months. See, observation for 6 months, it is like too late and risky, right? There is no preventive benefit. So there is a very high scope for the development of hepatitis B. Okay, so first option wrong. And vaccine only, see, when you are giving vaccine, you're just providing only active immunization. So in case of an unvaccinated individual, if you provide only active immunization, this is like inadequate, right? So active immunization is inadequate alone for immediate protection. So this will not provide immediate protection, right? Then what is required? Active immunization, and as well as the passive immunization is being required. And no action if LFTs are normal. See, LFTs are not the one which will assess the immunity of the individual, and LFTs are not the one which will prevent the infection. So if LFTs are normal, it does not mean that the individual does not require the vaccine. So your option D is also incorrect. So in this individual, what is required? You need to administer both the hepatitis B vaccine, which will provide the active immunity, and hepatitis B immunoglobulin, which will provide the passive immunity. Done? Okay, so if you see the next question, a patient with decompensated liver cirrhosis present for deep scaling. INR is like 2.4, the platelets are like 70,000 per cubic millimeter. What is the most important dental precaution? What is the most important dental precaution? So first option, prescribe antibiotics before and after the procedure. Avoid all the dental procedures permanently. Third option, use local hemostatic agents and avoid the NSAIDs. Then perform procedure under the general anesthesia. So the explanation here is, you need to use the local hemostatic agents and avoid the NSAIDs. Okay. So these local and platelet count is 70,000, INR is 2.4, patient with decompensated liver cirrhosis. So you need to use the hemostatic agents that will reduce the bleeding risk, right? And avoid NSAID. Why? Because these NSAIDs, they have potential hepatotoxicity. Right, they have potential hepatotoxicity. So here the patient is having a decompensated liver cirrhosis. Okay, right? And the another important is, these NSAIDs, they also cause the platelet inhibition. Right, they also cause the platelet inhibition. Okay, so that is the reason why you need to use the local hemostatic agents and you need to avoid the non-steroidal anti-inflammatory drugs. Done? Now, what about the other options? Antibiotics. See, antibiotics, they are not indicated unless there is an active infection or risk of endocarditis. Okay, so because there is no active infection, right? Because there is no active infection or endocarditis, you don't require to give the antibiotics in this scenario. And you take second option, avoid all dental procedures permanently. See, avoiding dental procedures is unnecessary, right, with proper precautions. Okay, so with proper precautions you can go ahead. It is unnecessary, like you need to avoid all the dental procedure. Then perform procedure under general anesthesia. So performing the procedure under general anesthesia, this also should be completely avoided, right? And the general anesthesia, it is highly risky in cirrhotic patients. Right? It is highly risky in case of cirrhotic patients. So that is about the general anesthesia. So the answer to this question is, you need to use local hemostatic agents and avoid the non-steroidal anti-inflammatory drugs. Then, which oral manifestation is commonly seen in patients with the chronic liver disease? Strawberry tongue, angular cheilitis, petechiae and ecchymosis on the oral mucosa, then gingival hyperplasia. So the oral manifestation that is commonly observed in case of the chronic liver disease is the petechiae and ecchymosis on the oral mucosa, right? And why is this? Let me explain to you. So in liver disease, the problem is coagulopathy, right? The problem is the coagulopathy and thrombocytopenia. right? That is decrease in the platelets. Okay, so thrombocytopenia and coagulopathy in liver disease, this may present right, this may present as the petechiae, right, or ecchymosis in the oral cavity. Right, or ecchymosis in the oral cavity. Understood? So in chronic liver disease, the bleeding manifestations are common. And what about the other options like strawberry tongue? Strawberry tongue, this is very much commonly observed in Kawasaki disease. Right, so this is commonly observed in case of Kawasaki disease, right? And the scarlet fever, this strawberry tongue, seen in Kawasaki and as well as the scarlet fever. So the difference is, like in Kawasaki you will have white strawberry tongue, whereas in scarlet you will have red strawberry tongue. But this strawberry tongue is not the feature of the chronic liver disease. Next is angular cheilitis. So if you take this angular cheilitis, this is linked to vitamin deficiencies, but it is not observed in case of liver disease. Next is gingival hyperplasia. This gingival hyperplasia, this is seen in the toxicity with phenytoin, right? This is seen in the toxicity with cyclosporin, right? So phenytoin and as well as cyclosporin, or even in patients with acute myeloid leukemia, you will observe the gingival hyperplasia. And this gingival hyperplasia is not the feature of your chronic liver disease, right? So the answer in this question is petechiae and as well as ecchymosis on the oral mucosa. Then the next question, if you observe, which hepatitis B antiviral require caution in dental patients due to bone marrow suppression and the oral ulceration? The options are entecavir, tenofovir, interferon alpha, and then the lamivudine. So the one which requires the caution in dental patients due to bone marrow suppression and oral ulceration, it is your interferon alpha. This interferon alpha, this may cause the mucositis, right? And this may also cause the oral ulcers, and this will also cause the cytopenias. So mucositis, oral ulcers, cytopenias, these are the one which can affect the dental treatment by the interferon alpha. And you take this entecavir, which is used as an antiviral drug, it has a minimal oral side effects, right? This has a very minimal oral side effects. So this entecavir, this is generally well tolerated. What about this tenofovir? Tenofovir may cause renal toxicity, right? Tenofovir may cause renal toxicity, but no significant oral issues. So that is the reason why tenofovir, there is no major dental specific concern. Next is lamivudine. Lamivudine is also generally well tolerated, and this particular lamivudine, it is not associated with bone marrow suppression, right? And you will not have the oral ulceration. Right, you will not have the oral ulceration with lamivudine. So the answer here is the interferon alpha. Done. Then followed by that, you see the next question. A dental professional receives 3 hepatitis B vaccine doses. Anti-HBs titer after 2 months is less than 10 international units per ml. What is the next step? The options are like booster every 6 months, start post-exposure prophylaxis, revaccinate with full 3-dose schedule, consider individual protected. So 3 HBV doses has been taken by the individual, but the anti-HBs titer after 2 months is less than 10 international units per ml. What is the next step that you need to do is, you need to again revaccinate with full 3-dose schedule, right? So if the titer is less than 10 international units per ml, this indicates that there is no response. Right, this indicates that there is no response. So what is required now? Full vaccination or full revaccination is recommended. Right, full revaccination is recommended. So according to CDC and WHO guidelines, the appropriate next step is to revaccinate with a second full 3 doses. Right, 3 doses. So the CDC or the WHO guidelines say that you need to revaccinate the individual with complete 3-dose schedule. And after revaccinating with full 3-dose schedule, again you need to retest. Right? Again you need to retest. Anti-HBs 1 to 2 months after the final dose. Right, so 1 to 2 months after the final dose, you need to retest again. So this is about like what you have to do. Like once you have given 3 doses, but the titer is less than 10, you need to revaccinate and again test after 1 to 2 months after the final dose. Okay. Now, next question, if you see, which dental drug should be used with precaution in the hepatic impairment? The options are amoxicillin, metronidazole, chlorhexidine, then paracetamol. So it is your paracetamol which is hepatotoxic. Right, paracetamol, it is hepatotoxic. So paracetamol is hepatotoxic in overdose and should be dose adjusted. Right, so this should be dose adjusted in the liver disease. And what about the amoxicillin? The amoxicillin, it is excreted primarily through the kidney. So no major hepatic concern. And you take this metronidazole. Metronidazole, it is via the hepatic metabolism. So you need to adjust in liver disease. Right, you need to adjust in liver disease, right? But in mild cases, it is generally safe. Right, so mild cases, it is generally safe. And you take this chlorhexidine. This chlorhexidine, this is like topical or the local use. Right, so this is like topical or the local use. Okay, so this chlorhexidine, because it is like topical or local use, systemic absorption is negligible. Right, systemic absorption is negligible. So this is about your chlorhexidine. So what is the answer here? It is the paracetamol. It is hepatotoxic, right, in overdose. And that is the reason why this paracetamol should be dose adjusted in the liver disease, right? So this is about the important drug in hepatic impairment that has to be dose adjusted or monitored. If you see the next question, we have a 48-year-old female presents with the chronic dry mouth, dental caries, and complains of gritty sensation in her eyes. Shimmer's test is positive and anti-SSA antibodies are elevated. Which complication is she most at risk for? The options are mucormycosis, parotid gland carcinoma, non-Hodgkin's lymphoma, then osteonecrosis of the jaw. So this clinical scenario is suggestive of the Sjogren's syndrome, right? So it is in case of the Sjogren's, your SSA and SSB antibodies will be positive. Okay, so these patients with Sjogren's, they are at increased risk of the salivary gland lymphoma, right? And this particular salivary gland lymphoma, it is a non-Hodgkin's lymphoma. Okay, so this individual is at risk of salivary gland lymphoma, right? And this salivary gland lymphoma, it is particularly MALT, okay, that is mucosal associated lymphoma. And the most serious complication, it includes, right, the most serious complication includes the increased risk of, right, it includes increased risk of non-Hodgkin's lymphoma, right? And this non-Hodgkin's lymphoma, it is especially especially marginal zone or MALT lymphoma. Okay, so this is like very common in patients with the Sjogren's. What about the other options? So if you take this mucormycosis, it is seen in diabetic patients, right? Or it is observed in immunocompromised individual. And this mucormycosis, it is not typical in Sjogren's. So this mucormycosis is ruled out. And you take parotid gland carcinoma. Parotid gland carcinoma, this is rare, right? And what is like very common is the parotid lymphoma. Right, so parotid lymphoma is more common, right? Then if you take this non-Hodgkin's lymphoma, this is like most serious and well-known complication that you observe in case of the Sjogren's syndrome. And you take this osteonecrosis of the jaw. This osteonecrosis of the jaw, right, this is like commonly observed with, right, this is commonly observed with bisphosphonate therapy, but not with the Sjogren's syndrome. So the answer here is the non-Hodgkin's lymphoma, which is very common in case of the Sjogren's. Done? Now, so if you see the next question, we have a 60-year-old man with long-standing rheumatoid arthritis, complaining of jaw stiffness, clicking, and difficulty in opening her mouth. What is the most likely joint affected? Sphenomandibular joint, temporomandibular joint, mandibular symphysis, then maxillary tuberosity. So in case of rheumatoid arthritis, it is the temporomandibular joint which is like very commonly affected. And this particular temporomandibular joint, it is, right, so it is a synovial joint which is commonly affected in rheumatoid arthritis. And this temporomandibular joint which is affected in rheumatoid arthritis, this will lead to stiffness, right? So this will lead to stiffness, and the individual will be having difficulty, right, difficulty in the dental procedures, right? They'll be having stiffness and difficulty in the dental procedures. Now, as such, you take in case of rheumatoid arthritis, the most common joints which are affected is the small joints. And what are these small joints which are affected is metacarpophalangeal joint and as well as the interphalangeal joint. But you don't have the involvement of the distal interphalangeal joint in case of the rheumatoid arthritis. And the large joints involvement in case of the rheumatoid arthritis will be late and they are rare. And cervical spine is affected, and that too, which joint in the cervical spine? It is atlantoaxial joint dislocation is what is commonly observed in case of the rheumatoid arthritis. Done? And almost 40% of patients, they also have the extra articular manifestations, right? They also have the extra articular manifestations. And the most common extra articular manifestation is like the cutaneous manifestation, that is subcutaneous nodules These subcutaneous nodules, they are commonly observed over the extensor surface of the forearm, right? And if at all, if there is mortality in patients with rheumatoid arthritis, it is mainly because of the congestive cardiac failure. And the investigation of choice in patients with rheumatoid arthritis will be anti-CCP. Whereas you take rheumatoid factor is not specific for rheumatoid arthritis, right? Multiple other conditions you have the RA factor being positive. But anti-CCP, it is like the investigation of choice. Whereas in the treatment, the drug of choice in patients with the rheumatoid arthritis will be methotrexate. Okay, so the drug of choice will be methotrexate. So this is in a nutshell about rheumatoid arthritis. In rheumatoid arthritis, the joint which is commonly affected is your temporomandibular joint. And what about this sphenomandibular joint? The sphenomandibular joint, it is not a true joint. It's just a ligament. Okay, so it is not affected in rheumatoid arthritis. And temporomandibular joint is a synovial joint. This is what is like commonly affected in patients with the rheumatoid arthritis. Then mandibular symphysis, it's a fibrocartilaginous union, right? So this is not a synovial joint and it is not affected in rheumatoid arthritis. Then maxillary tuberosity, it's a part of the maxilla, it is not a joint, and this is not involved in the rheumatoid arthritis. Okay, so the one which is like affected is the temporomandibular joint. Done. Next question. So a 34-year-old woman with systemic lupus erythematosus presents with the painless palatal ulcers and positive anti-nuclear antibody. She's on steroids. Which of the following features support an SLE related oral lesion? The options are vesicles with pain and bleeding, then erythematous border with central necrosis on the hard palate, then bilateral buccal white patches, then painful lip crusting. So what is the oral lesion that supports the systemic lupus erythematosus? That is the erythematous border with central necrosis on the hard palate. That is the one which supports the SLE oral lesion, right? So SLE oral ulcers, these are typically painless, right? These are typically painless. And where are they distributed? They are distributed over the palate, and they will be having the central necrosis, and they will also have the erythematous border, that is red margins will be present. And what about the other options, like if you see the vesicles in with pain and as well as bleeding. Vesicles with pain and as well as bleeding, this is more characteristic of the viral infection. And which viral infection you have this vesicles with pain and bleeding is? It is the herpes simplex virus infection, right? Then you take the third option, bilateral buccal white patches. Bilateral buccal white patches, this is suggestive of, right? So this is suggestive of the lichen planus, right? This is suggestive of lichen planus. And you take this painful lip crusting. Painful lip crusting, it is seen in the herpes labialis. Right, so it is observed in the herpes labialis, or it is observed in case of the Steven-Johnson syndrome. Okay, so the answer in this question is erythematous border with central necrosis on the hard palate. And you take the patients with SLE, some of the diagnosis is very, very important. If the question is asked like what is the most specific antibody in patients with SLE, the answer is the anti-Smith. And if the question is asked like what is the most sensitive antibody, the most sensitive antibody is the anti-nuclear antibody. The antibody which will tell you about the CVRT, right? The antibody which will tell you about the CVRT is anti-DS DNA, right? Anti-DS DNA. And in case of drug-induced SLE, the antibody is the antihistone antibody. And this SLE, it is a multi-system disorder, right? So most commonly these patients with SLE, they present with like the fatigue, joint pain, myalgia, arthralgia. This will be the common presentation in patients with the SLE, right? And almost all the systems, you have cardiac involvement in the form of pancarditis, lung involvement in the form of pleuritis, pleural effusion and interstitial lung disease. Neurological involvement also will be there in patients with the SLE in the form of like seizures. Renal involvement also will be there in the form of lupus nephritis. Oral cavity involvement can also be observed in the patient in the form of the oral ulcers. So the drug of choice with acute flares of SLE is that you need to give steroids. Okay, so steroids, they are considered as the drug of choice. Okay, so this is about in nutshell related to the systemic lupus erythematosus. Now, so if you see the next question, a patient with diffuse systemic sclerosis and history of bisphosphonate use of osteoporosis presents for extraction. What is the most serious dental complication? Already we have discussed this question, but I just want to discuss few points related to systemic sclerosis in this question. The options are osteomyelitis, bisphosphonate related osteonecrosis of the jaw, pathological fracture, temporomandibular joint ankylosis. So like with bisphosphonate therapy, what is that you will observe? That is bisphosphonate related osteonecrosis of the jaw, right? And these bisphosphonates, they are at increased risk of the osteonecrosis, right? So that is why we give the term this BRONJ. Now these bisphosphonates, the examples include like zoledronic acid, ibandronate, right? So these are your bisphosphonates which are given mainly for the treatment of osteoporosis. Now, what about the other options? Before that, let me just tell you a few points about the systemic sclerosis. Okay, before that, how will you rule out the other options? You take osteomyelitis. Osteomyelitis, it is possible in the given scenario, but less specific, right? But is less specific, okay? And the pathological fractures, if you take the other option, pathological fractures in this scenario of like systemic sclerosis with bisphosphonate therapy, it is rare and it is not primary concern in this setting. And temporomandibular joint ankylosis, it is more associated with trauma or ankylosing disorders and it is not associated with the bisphosphonate. And if you take this systemic sclerosis, right, in these individuals with systemic sclerosis, you will be having rapid skin involvement. Okay, you take, like we have two major forms, like one is systemic sclerosis, the other one is limited scleroderma. In limited scleroderma, you have slow cutaneous involvement, and visceral organ involvement will be late in case of limited scleroderma. Whereas in case of the systemic scleroderma, you have a rapid skin involvement, right? You have rapid skin involvement, and along with that, you will have early visceral organ involvement. Right? You will have the early visceral organ involvement. Okay. And the next important in case of systemic sclerosis, like what is the antibody? The antibody in systemic sclerosis will be anti-topoisomerase antibody, right? Or anti-SCL70, right? Or the anti-SCL70. That is what the antibody that you will observe in case of the systemic sclerosis. And in case of systemic sclerosis, like if at all, if the individual has to have mortality, that is like mainly because of the cardiac involvement, and the cardiac involvement in these patients with systemic sclerosis will be in the form of the restrictive cardiomyopathy, right? And what is the treatment that you'll be giving in these individuals is the steroids, because this is an autoimmune condition, you need to give steroids. But whereas the antibody you take in case of limited scleroderma, it is different. In limited scleroderma, the antibody is the anti-centromere antibody, and even your scleroderma is also a multi-system involvement. And particularly you take like in systemic sclerosis, the individual skin will be fibrosed so much, the individual will not be able to open them out completely. So they will be having this microstomia, right? The oral cavity will be small because of the fibrosis of the skin or the angles of the mouth. That is what you will observe in patients with the systemic scleroderma. Okay. So in case of systemic scleroderma, like if the individual is also parallelly taking the bisphosphonates, there is like risk of the osteoporosis. There is bisphosphonate related osteonecrosis of the jaw is commonly observed. Done. Next question. Which of the following is a common orofacial manifestation in a child with polyarticular juvenile arthritis? gingival hyperplasia, delayed eruptions of the molars, ankylosis of temporomandibular joint, then microglossia. So the correct answer here is the ankylosis of the temporomandibular joint. Temporomandibular joint ankylosis in case of the polyarticular juvenile arthritis, this leads to limited mouth opening. Right, so this leads to limited mouth opening, and there will also be facial growth abnormalities. Right, there will also be facial growth abnormalities, right? And you take this gingival hyperplasia. Gingival hyperplasia, this is like most commonly observed with drugs. And what are the drugs? That includes phenytoin and then cyclosporin. And this is also commonly observed in case of leukemias like acute myeloid leukemia. And what about this delayed eruption of the molars, right? This delayed eruption of the molars, this is not, right, this is not the direct or common feature of the juvenile arthritis. And you take this microglossia, this is a congenital condition. And even this is not observed with the GIA. Okay, so this is about the features that you will have in child with polyarticular GIA. Done. Move on to the next question. 52-year-old male with polymyalgia rheumatica on long-term prednisolone undergoes periodontal flap surgery. What complication should you monitor for? The acute adrenal crisis, gingival bleeding, then trigeminal neuralgia, then the hyperkalemia. So the individual is on long-term prednisolone. So this prednisolone being a steroid, when the individual is on long-term steroid therapy, that is corticosteroid therapy, this leads to suppression of the hypothalamo-pituitary adrenal axis. This leads to suppression of the hypothalamo-pituitary adrenal axis. And this can result in the acute adrenal crisis. Now, why, particularly during when the individual is on long-term prednisolone? Now, why in this patient? Because the individual is like undergoing a periodontal flap surgery, right? So it is a form of a surgical stress, right? It is a form of surgical stress, right? The body may not produce enough endogenous cortisol. Right? The body may not produce enough endogenous cortisol, and that can lead to the acute adrenal insufficiency. And what will be the features that you will have in case of acute adrenal crisis is, these individuals will be having hypotension, and these individuals will also have the hypoglycemia, and these individuals may go into a state of shock, and these individuals may go into a state of the fatigue and nausea, right? So like what is important for them in this individual once they go into an acute adrenal crisis is, they will be requiring intravenous steroids, and that too intravenous hydrocortisone is required once they go into a state of the acute adrenal crisis during this surgery. And why particularly hydrocortisone? Because hydrocortisone is the one which has the dual activity. It has the steroid activity, and it also has the aldosterone activity, that is mineralocorticoid activity. So that is the reason why these patients they require the intravenous hydrocortisone, right? Now, what about the other options? You take this gingival bleeding. See, this gingival bleeding is possible, but not directly related to the steroid use, right? So this is this gingival bleeding. This is not directly related to the steroid use. And the next option is the trigeminal neuralgia. Trigeminal neuralgia, it is unrelated to the steroid use. right? It is unrelated to the steroid use. And the next one is the hyperkalemia. So long-term steroids, right? Long-term steroids can cause hypokalemia but not hyperkalemia. Right, long-term steroids can cause hypokalemia but not the hyperkalemia. Okay, so this is about, right, the acute adrenal crisis which is observed in those individuals who are on long-term prednisolone undergoing the periodontal flap surgery. Done. Next. So if you see the next question, a patient with Raynaud's phenomena is undergoing a 60-minute dental procedure. Which of the following is a critical preventive strategy? Avoid vasoconstrictors in local anesthesia. Use ice packs for the hemostasis. Elevate the head during the treatment. Then prefer the general anesthesia. So the individual is having Raynaud's. So it is the scenario where there will be vasoconstriction on exposure to cold. That is a problem in case of Raynaud's. Okay, so in patients with Raynaud's, you need to avoid vasoconstrictors, right? Because vasoconstrictors in a patient with the Raynaud's, they can, right, they can worsen digital ischemia. Right, they can worsen digital ischemia. So what is that you need to do is, you need to use, right, you need to use a plain local anesthesia in Raynaud's patient. Okay, so now you take the other options. What about use ice packs for the hemostasis? See, the ice packs like contraindicated. Okay, these are like contraindicated because cold can trigger the Raynaud's attack. So that is the reason why it is completely the incorrect statement. Okay, and elevate the head during the treatment. This is the routine practice. This is not specific to Raynaud's. Any dental procedure, you need to elevate the head. And prefer general anesthesia, not necessary unless severe systemic issues are being present. So that is the reason why these are incorrect. So what is the correct statement? Like, you need to avoid vasoconstrictors in local anesthesia. What is that you need to use? A plain local anesthesia should be given because this vasoconstrictors can trigger or precipitate the digital ischemia. Done. Next question. A 40-year-old female on methotrexate for rheumatoid arthritis presents with multiple painful oral ulcers and pancytopenia. So what is the likely cause in this patient? RA disease flare, poor oral hygiene, methotrexate toxicity, then viral stomatitis. So this patient is on methotrexate for rheumatoid arthritis and they present with the multiple painful oral ulcers and pancytopenia. So the likely cause is methotrexate toxicity. It is this methotrexate toxicity, this will cause the oral ulcers. Right, this will cause the oral ulcers. And the methotrexate toxicity is the one which will cause the bone marrow suppression. Right. So this oral ulcers looks like the mucositis. Okay. And this pancytopenia, whichever is there in the clinical picture, this is mainly because of the bone marrow suppression caused by the methotrexate. And what about the other options? See, that is the reason why whenever you are taking this methotrexate, what is that you need to advise to the patient? The dosage of methotrexate is 5 to 20 milligrams and this has to be taken once a week. And this methotrexate is a folate antagonist. So, right, so remaining 5 days, these patients should be given the folate or the folinic acid. Right, folate or folinic acid should be given remaining 6 days, I'm sorry. Right, remaining 6 days. So once a week you need to give this methotrexate. Now suppose if the interpretation by the patient is like reverse, So if the patient is taking like methotrexate 6 days and 1 day folate, this is associated with methotrexate toxicity, right? This is associated with methotrexate toxicity. Okay, so and what about the other options? RA disease flare, rheumatoid arthritis disease flare doesn't typically cause pancytopenia or the mucosal ulcers. Doesn't typically cause pancytopenia or mucosal ulcers. Okay, right? And the poor oral hygiene can cause gingivitis but not pancytopenia. So this is wrong. Methotrexate toxicity is the one which can cause the oral ulcer and as well as pancytopenia. And what about the viral stomatitis? Viral stomatitis can cause ulcers, but this does not explain the pancytopenia component. So that is the reason why your viral stomatitis is also ruled out. Okay, so the correct answer here is the methotrexate toxicity. And this methotrexate, it is being used for multiple other disorders also. Like one is definitely yes, rheumatoid arthritis. For rheumatoid arthritis, methotrexate is considered as the drug of choice. And many other connective tissue disorders, we use this methotrexate because of the anti-inflammatory activity of your methotrexate. And for rheumatoid arthritis, there are multiple other drugs apart from methotrexate. The other drugs apart from methotrexate, if the patient does not have an adequate response to methotrexate, then the other drugs that can be added is the hydroxychloroquine, right? The other drugs that can be added is the sulfasalazine. Okay, so this will be the triple therapy in patients with the rheumatoid arthritis. Done. Next, a 26-year-old ANA positive woman with mixed connective tissue disease presents with gingival overgrowth. Which medication is most likely responsible? Hydroxychloroquine, prednisolone, amlodipine, then the azathioprine. So the individual is like ANA positive and then the MCTD presents with gingival overgrowth. The medication that is responsible among the options given to you is the amlodipine. So amlodipine, this is like a calcium channel blocker, and this can cause, right? So this can cause gingival hyperplasia, especially in mixed connective tissue disease patients. Right, in MCTD patients, this amlodipine is associated with gingival hyperplasia. And the gingival overgrowth, also known as gingival hyperplasia, is a well-known adverse effect with not only these calcium channel blockers, right? So previously I have discussed, even it is associated with the phenytoin. Even it is also associated with cyclosporin. Right, even it is also associated with the cyclosporin. Okay. Now what about the hydroxychloroquine? Hydroxychloroquine, it is a drug which is given in the treatment of the rheumatoid arthritis, and not only rheumatoid arthritis, we also use in the treatment of systemic lupus erythematosus, and this is not associated with the gingival overgrowth. And you take the prednisolone, which is a steroid. What this prednisolone can cause in the oral cavity is, the prednisolone, it can cause thinning of the gums, right? This can cause thinning of the gums. That is the problem with the prednisolone, but this will not cause the gingival hyperplasia. And next is azathioprine. If you take this azathioprine can cause myelosuppression, right? But not gum changes. Right, but it is not associated with the gum changes. So that is about the azathioprine. And what is this azathioprine? It's an immunosuppressant. It's an immunosuppressant. So this is about the amlodipine, which can cause the gingival overgrowth. Then next, a patient with ankylosing spondylitis presents with the oral prophylaxis. He has significant cervical spine fusion. What is the primary precaution? Use prone position for the treatment. Avoid bite-wing radiographs. Support neck and limit the neck extension. Then use steroids before the scaling. So in this scenario, where there is like the significant cervical spine fusion, the primary precaution what is required is, you need to support the neck and you need to limit the neck extension. Because in ankylosing spondylitis, there is like cervical fusion, right? So if at all, when you do this neck extension can cause injury, right? Neck extension can cause injury. So that is the reason why, right? So that is the reason why proper support, it is very much critical during the dental care. Proper support is very much critical during the dental care. Okay, so use prone position for the treatment. This is not ideal, right? This is not ideal. So supine or semi-reclined, right? Supine or semi-reclined, this is better mainly for respiratory and as well as the spine care, right? As well as the spine care. Okay, so first option incorrect. And you take this, avoid bite wing radiographs. So this bite wing radiographs, this can be like taken in patients with the ankylosing spondylitis. Steroids before scaling. Steroids before scaling, this is not routinely required unless there is an adrenal suppression. So if at all, if there is an adrenal suppression, then the steroids can be given. So use steroids before scaling, not required. And as such, if you take this ankylosing spondylitis, the joint which is commonly affected in ankylosing spondylitis is the sacroiliac joint, right? That is number one. Then you have the involvement of the spine, where you will notice that there is fusion of the vertebra, right? Where you will notice that there is fusion of the vertebra, right? And in ankylosing spondylitis, what is the most common? Extra-articular manifestation. The most common extra-articular manifestation in ankylosing spondylitis is the anterior uveitis. So anterior uveitis is the most common extra-articular manifestation. And you also have cardiac involvement in the form of aortic regurgitation, and there can also be the complete heart block in patients with the ankylosing spondylitis. And in patients with the ankylosing spondylitis, right, what is the HLA association? It is the HLA B27, and you need to do the imaging, that is X-ray of the sacroiliac joint and as well as spine. When you do the X-ray of the spine, this will show you the presence of the bamboo spine. And the drug of choice is NSAIDs, and the drug that we give is indomethacin, right? Indomethacin. So this is what is the treatment in case of the ankylosing spondylitis. Okay, so this is about the question related to ankylosing spondylitis, like where you need to support the neck and you need to limit the neck extension. So if you see the next question, so a 50-year-old female complains of sudden, sharp, electric shock-like pain over the right lower jaw, and this is triggered while brushing her teeth. What is the most probable diagnosis? The options are the dental caries, trigeminal neuralgia, temporomandibular joint disorder, maxillary sinusitis. So sudden, sharp, electric shock-like pain over the right lower jaw. So this is what is suggestive of the trigeminal neuralgia. So this trigeminal neuralgia, the pain or electric shock-like sensation, this will be paroxysmal in onset, right? So this will be paroxysmal in onset, that is sudden in onset, and this particular pain will be unilateral. And now in which particular distribution you will be having this particular pain? So you will be having this electric shock or painful like sensation in the maxillary division, then in the mandibular region. Okay, and these are the areas where you will be having the electric shock like painful sensation in case of trigeminal neuralgia, and you have a triggering factors, that is light touch and as well as chewing sensation. These are the triggering factors, right? Now in case of the trigeminal neuralgia, what exactly is the drug of choice? So if you see the treatment in case of the trigeminal neuralgia, the drug of choice is the carbamazepine, right? And if the patient does not have the adequate response, with carbamazepine, the next important molecule that you need to administer is the oxcarbamazepine. And what is the surgical treatment? The surgical treatment includes rhizotomy. Right? The surgical treatment includes rhizotomy, right? Where we need to dissect the root of the trigeminal nerve root. So that is like the surgical treatment. So in case of the trigeminal neuralgia, the pain will be unilateral. Mostly it is unilateral and occasionally it is bilateral. And this trigeminal neuralgia, it is more common in males rather than females, right? And this trigeminal neuralgia is around the age group of the 50 years. And what about how will you rule out the other options? You take the dental caries. So dental caries, that usually causes like, okay, so if you take the other options like the dental caries that usually cause a dull and continuous pain. It is not like, right? It is not like the pain of, okay, it is not like the pain of trigeminal neuralgia where you have electric shock like sensation. No, right? And that too paroxysmal in trigeminal neuralgia. Whereas in dental caries, it is a dull, continuous pain. And this particular pain of dental caries, it is aggravated by exposure to cold and it is aggravated by exposure to hot. But the dental caries will not have the electric shock like sensation. And the next important is the temporomandibular joint disorder. So, the temporomandibular joint disorder, this is like typically dull in character. The pain will be dull in character and this pain will be an aching pain and this worsens with the jaw movement. Right, the temporomandibular joint disorder pain, this worsens with the jaw movement. And this particular temporomandibular joint disorder, it is not sudden or shock-like. Right, it is not sudden or shock-like. Whereas in trigeminal neuralgia, it is like sudden and shock-like. But temporomandibular joint disorder, it is like dull, aching and worsen with jaw movement and it is not sudden or shock-like. Then the other option is maxillary sinusitis. Maxillary sinusitis, this causes pressure-like pain over the cheeks. Right, so this will cause the pressure like pain over the cheeks, and this maxillary sinusitis, it is not sharp and it is not triggered by the brushing or light touch. Okay, that is what is your maxillary sinusitis. So the answer in this question is the trigeminal neuralgia. Done. Now we'll move on to the next question. A non-epileptic patient develops tonic-clonic seizures during a dental procedure. What is the first step in the management of this patient? First option, administer phenytoin intravenous immediately, insert a mouth gag to prevent the tongue biting, remove dental instrument and protect the patient from injury, and give oxygen and continue the procedure. Right, so the individual is having tonic-clonic seizures during the dental procedure. What is that you need to do first immediately is remove the dental instrument and protect the patient from the injury. Right, protect the patient from injury. So during an episode of seizure, like you need to stop, right, you need to stop all procedures, protect the patient and ensure the safety. Okay, and do not place, okay, do not place objects in the mouth of a patient with the GTCS. When the individual is having having a GTCS episode and you are doing a dental procedure, do not place any object in the mouth. So what are the key steps? The key steps will be stop the procedure, remove all the instruments from the mouth, and next thing is you clear the surroundings and protect the patient from injury. And next important, monitor the airways and as well as the vital signs of the patient, that is blood pressure and as well as the pulse rate, respiratory rate and saturation. And if the seizures are persisting for more than 5 minutes, right, if the seizures are persisting for more than 5 minutes, then you need to give benzodiazepine, that is lorazepam should be given if the seizure is persisting for more than 5 minutes. Right, now what about the other options? you administer phenytoin intravenously immediately. This is not the first step. Administering the phenytoin is not the first step. And the intravenous medications are used after ensuring the safety and if the seizure is prolonged. So first option is incorrect. And you take the second option, insert a mouth gag to prevent the tongue biting. So placing any object is contraindicated during the active seizure. Okay, and risk of injury to both patient and as well as the provider as well during the episode for placing any object in the mouth. So your second option wrong. Fourth option, give oxygen and continue the procedure. Oxygen is useful after initial stabilization. So what is required first is initial stabilization is required. Okay, so initial stabilization is required and never continue the procedure during the seizure episode. So that is about your fourth option being also incorrect. So the point here is remove the dental instrument and protect the patient from injury is the first thing. Then next question, a 40-year-old male presents with inability to close the right eye, and there is also drooping of the mouth corner and deviation of the angle to the left side. What is the most likely cause? Trigeminal neuralgia, myasthenia gravis, Bell's palsy, and then stroke. So the answer in this scenario is the Bell's palsy. Bell's palsy, this is a lower motor neuron type of lesion, and this lower motor neuron type of lesion, this is the one which will cause the weakness, right? So this is the one which will cause weakness on the entire side of the face, right? This is the one which will cause the weakness of the entire side of the face. And this patient with the Bell's palsy, they will also have inability to close the eye. Right, the individual will also have inability to close the eye. So that is what you will have in case of Bell's palsy. And Bell's palsy, it is a LMN lesion. Now what are the features of difference between the LMN and the UMN facial nerve palsy? Now you take in case of the LMN, if you take the eye closure is impaired in LMN palsy, whereas in UMN palsy the eye closure is preserved. And next important is the forehead movement. If you see the forehead movement in case of Bell's palsy, it is absent, whereas in upper motor neuron lesion, the forehead movement is preserved. Next is mouth deviation. Mouth deviates to the opposite side in case of the LMN palsy, right? And even in case of UMN palsy also, it will deviate to the opposite side. And the next important is the involvement of the face. So if you take the involvement of the face in LMN palsy, that is Bell's, it is the entire half of the face is paralyzed, whereas in UMN palsy, it is only, right, it is only lower half of the face is involved. So that is what is the difference between the LMN and as well as the UMN palsy, right? Now how will you rule out the trigeminal neuralgia? See, trigeminal neuralgia, it affects the sensation. So in case of trigeminal neuralgia, you don't have the motor involvement. There is no motor involvement. There is no facial droop. There is no eye closure issues in case of the trigeminal neuralgia. Next is myasthenia gravis. How will you rule out myasthenia gravis? Myasthenia gravis, it causes fatigable weakness. So the very important feature in this individual is the fatigable weakness. And in case of myasthenia gravis, these individuals will have the ptosis, right? These individuals will have ptosis, okay? Then followed by that, how will you rule out the stroke? See, stroke, it is a UMN lesion, right? Stroke is a UMN lesion. And this particular stroke, it spares the forehead. Right? This stroke, it spares the forehead. And eye closure is also preserved. That is what in case of the stroke. Okay. So the one, how will you rule out the Bell's palsy from the other options? Now we'll move on to the next question. So a 72-year-old patient with Parkinson's disease, they present with the tooth extraction, presents for tooth extraction. Which of the following precaution is most important? Schedule appointment late evening, avoid local anesthetic, schedule the treatment shortly after the medication dose, and ask the patient to skip the morning medicines. So in patients with Parkinsonism, you need to schedule the treatment shortly after the medication dose, right? You need to schedule the treatment shortly after the medication dose. Okay. Now you take the dental treatments. The dental treatment should be timed 60 to 90 minutes after the medication. Right? 60 to 90 minutes after the medication. So these dental treatments, which should be timed 60 to 90 minutes after the medication, they are mainly to minimize the tremors. So this will minimize the tremors, right? And this will also improve the cooperation, right? This will also improve the cooperation. Okay. So this is when the tremors are reduced and when there is improved cooperation, this is when their motor function is optimally controlled, right? Their motor function is optimally controlled. So this will minimize the movements, this will minimize the rigidity, this will minimize the anxiety during the procedure. So that is what is like schedule the treatment shortly after the medication dose. And what about the other options? Schedule appointment late evening. See, late in the day, medication effects may have worn off. So in this scenario, the motor symptoms, they worsen, right? Next, second is avoid local anesthetics. See, there is no contraindication. Local anesthesia is safe and it is like preferred over general anesthesia. So you can give local anesthesia, and this is what is being preferred over the general anesthesia. Next, ask the patient to skip the morning medicines. Skipping the medicines can cause severe motor symptoms, right? Skipping the medicines can cause the severe motor symptoms, like there will be aggravation of rigidity, right? So that is the reason why ask the patient to skip the morning medicines is not correct. So the correct answer is schedule the treatment shortly after the medication dose. Done? Now, you see the next question. A patient had an ischemic stroke 3 months ago and he is on the aspirin. What is the best dental approach for the tooth extraction? The options are proceed with extraction under local anesthesia, stop aspirin 5 days prior to procedure, defer dental treatment for 6 months, refer to the neurologist immediately. So the individual is on aspirin and that took a dental procedure, which is a minor procedure. So you can proceed with the extraction under local anesthesia. Minor procedures like dental procedure, these can be safely performed in patients on aspirin using the local anesthetic or local hemostatic measure. And stopping of aspirin stopping of aspirin is not advised. Stopping aspirin increases the risk of stroke, right? So if you stop aspirin 5 days before prior to the procedure, that can increase the risk of stroke and that can increase the risk of thrombotic events, because the individual had stroke 3 months ago. So especially when you are stopping aspirin within 6 months of post stroke, there is increased risk of again thrombotic events. And the bleeding risk is very minimal and that can be managed with local hemostatic measures. And these local hemostatic measures include the pressure pack, right? The local hemostatic measures include the pressure pack and as well as the sutures, and even the supplementation of the tranexamic acid. right, supplementation of the tranexamic acid. Now what about the other options? Stop aspirin 5 days prior to the procedure. So stopping aspirin 5 days prior to the procedure increases the stroke risk. This is not recommended unless there is excessive bleeding being anticipated. Then defer the dental treatment for 6 months. So this is unnecessary delay. Okay, so deferring the dental treatment for 6 months is an unnecessary delay. This is not required for simple extractions if the patient is stable, and refer to the neurologist immediately. This is not needed unless the patient has had a very recent or the recurrent stroke. So the answer is proceed with the extraction under local anesthesia. Done. Now moving on to the next question. A patient reports throat pain which is radiating to the ear, especially during the swallowing or speaking. Dental examination is normal, and what is the likely diagnosis? Temporomandibular disorder, glossopharyngeal neuralgia, otitis media, maxillary sinusitis. So the likely diagnosis with the clinical picture which has been given to you is suggestive of the glossopharyngeal neuralgia. The glossopharyngeal neuralgia is the one which will cause a sharp pain in the throat and ear, right? You will be having sharp pain in the throat and as well as the ear. And this sharp pain in the throat and as well as ear, this is triggered by swallowing. Right? This is triggered by swallowing. Right? And what about the other options? You take the temporomandibular disorder. Temporomandibular disorder, it causes the jaw pain. Okay? So this will cause right, so this will cause the jaw pain, or this will give a clicking like sensation, and there will also be muscle tenderness in the individual. And in case of temporomandibular disorder, there is no throat pain, right? So throat pain radiating to the ear is not the feature of the temporomandibular disorder. Next is otitis media. So if you take this otitis media, this will cause ear pain primarily, right? The otitis media, it will cause the ear pain primarily, and this otitis media usually has the signs like fever. Okay, the individual will also have the hearing loss or the abnormal ear examination. That is what you will have in otitis media. Then you take in maxillary sinusitis. Maxillary sinusitis patients, these patients, they present with the facial pain. These patients, they present with the facial pain, and they will also have the congestion, and they will also have the postnasal drip. Okay, so these will be the features of the maxillary sinusitis, right? And this maxillary sinusitis is also not triggered by the throat pain. So the clinical picture this is suggestive is the glossopharyngeal neuralgia. Done. Now moving on to the next question. A patient with myasthenia gravis is undergoing a 2-hour dental procedure. What is the best management strategy in this patient? Delay all the dental treatments, schedule the evening appointments, administer treatment early in the day after medication, and use the long-acting sedatives. So the answer here is you need to administer, right? You need to administer the treatment early in the day after the medication. Okay, so morning appointments shortly after cholinergic medications, they reduce the fatigue. So that is the reason why administer the treatment early in the day after medications. So morning appointments shortly after the cholinergic medications, they reduce the fatigue and they ensure better patient cooperation. And what about the other important points? Morning appointments, like fatigue is least in the morning. That is the reason why morning appointments is preferred. Post medication timings, schedule the treatment shortly after the patient takes the anticholinesterase like pyridostigmine. And you need to delay all the dental treatments, right? Delaying all the dental treatments is unnecessary unless the disease is poorly controlled. Next, like schedule the evening appointments. So, risk of fatigue and weakness is higher, right? Risk of fatigue, it is very high in the evening. Next is long-acting sedatives. The long-acting sedatives, this may exacerbate the respiratory depression, right? This may exacerbate the respiratory depression and worsen the myasthenia gravis symptoms. Okay, so this is about, like, the correct point is administer the treatment early in the day after the medication, right? So last question. We have a 45-year-old postmenopausal woman complaining of burning sensation of the tongue and palate without any visible lesions. All lab tests are normal. What is the most likely diagnosis? Geographic tongue, oral candidiasis, burning mouth syndrome, the iron deficiency, anemia. So this picture is suggestive of your burning mouth syndrome. Burning mouth syndrome, it is seen in the postmenopausal women. Right, it is observed in postmenopausal women, and it is a diagnosis of exclusion with no clinical findings or abnormal labs. Right, so these patients with the burning mouth syndrome, they will be having like the normal oral examination, normal laboratory investigations, and this is very typical in the postmenopausal women, right? And this is neuropathic in origin, right? So this is neuropathic in origin and it is often idiopathic. And how will you rule out the other options? Like you take geographic tongue, this is characterized by erythematous patches. Right, this is characterized by erythematous patches on the tongue with white borders. Whereas you take this oral candidiasis, they present with word, right? It will present with white curd-like plaques over the tongue and as well as the palate, and this can be easily scraped off. So that is the reason why oral candidiasis is ruled out. Next is the iron deficiency anemia. See, burning mouth can occur but usually accompanied by the other signs. In case of the iron deficiency anemia, the oral examination will be pallor, glossitis will be there, angular cheilitis will be there, and abnormal labs. So these are the features of the iron deficiency anemia. So because the oral examination is normal, labs are normal, then we need to suspect the burning mouth syndrome in this scenario. So these are some of the important questions related to the test and discussion. Thank you very much.